So this time, I'm going to be talking about something I do every day. For some of you, you also do this every day. But I come with a different approach because I'm going to, in 15 minutes, tell you all about glaucoma. Dr. Feldman over there across the room has been doing this for over 40 years. So he's given me the look of, I'm going to see how you're going to make that happen. So let's get going. I'm going to start with this big diagnosis of what is glaucoma. But I want to focus on the things in yellow. Primarily, glaucoma is an optic nerve disease. I know we talk a lot about pressure. And in itself, what it does is that there is an accelerated death of the retinal ganglion cells, and that is what leads to the vision loss or functional loss that we have as patients with glaucoma. The eye has to keep its form. And so in order to retain its shape, there has to be something to occupy the inside of the eye. We have vitreous on the back, and we have aqueous on the front side, which is fluid. And there's a constant dynamic production of fluid and fluid egress in the eye. And when there's an imbalance, there's an elevation in intraocular pressure in the eye. Glaucoma is not one disease. Many times when people first get diagnosed, the thought of, I have glaucoma and it's one thing, and that's not quite the case. There are textbooks that talk about the types of glaucoma. There's open angle and closed angle glaucomas. There's different types of glaucomas that could occur. But generally speaking, most of them have to do with some kind of outflow problem, whether something is stopping up the drain or preventing fluid from leaving the eye. I put this example up here because generally most people with primary open angle glaucoma, which is a bulk of people with glaucoma, have open angle glaucoma, where fluid is produced. There's easy access to the drain of the eye, but the drain in itself is not functional, whether at the level of the trabecular meshwork, which I like to describe as the strainer over your kitchen sink, or beyond that, which is the rest of the plumbing in your house. There lies the problem in many cases. As that happens, what then goes on is that because there is an imbalance in pressure or in fluidics in the eye, fluid's being produced, it doesn't leave the eye, the pressure in the eye in certain instances could be elevated. And as that happens, imagine you have a balloon versus a soccer ball. If you put enough stretch on a balloon, it kind of stretches along. But for many of us, our eyes have a certain level of rigidity. And as you pressurize it, it will begin to the pressure will be applied at the weakest point. And in your eye, the area where the nerve fiber layers leave the eye, which is the optic nerve, is that point. So the pressure in the eye is felt around the optic nerve, leading to death of tissue in that area. And as you see, what then you see is a cupping. So we have on one side a normal optic nerve, on the other side an area where the nerve fiber layer has been lost and the size of the cup has increased, and there is a small hemorrhage there called a Drans hemorrhage that tells you that this eye is not very happy where the pressure is. How much glaucoma really is there? There is a lot of glaucoma out there, and we'll talk about that in the next 3 slides. It's the second most common cause of blindness in the US. It's more common in certain racial people, Africans or Hispanic race, and roughly 1% of the population in the US have glaucoma. Worldwide, there are 80 million people that were thought to have glaucoma in 2020, and right now, the assumption is that number, or the projection is that that number has doubled. As we talk about loss of vision from glaucoma, there are different ways of defining vision loss. There are people who absolutely can't see anything, but as we define loss of vision, there are several ways of defining visual loss. But if we add those two groups of people together, we would say about 7.75 million people have blindness from glaucoma, which 3.61 million being totally blind and 4.14 having some kind of severe visual impairment that requires assistance. The phases of glaucoma, that could be anybody. We had a session yesterday that addressed childhood glaucomas, but most glaucomas occur in older people. What we tend to hear about the most is elevated intraocular pressure, which is in red, but there's several other things there that could be risk factors for developing glaucoma. A family history is really important, and I would say stop at the AGS table, foundation table, because there's a program called AGS Cares that actually engages people to let their family members know so they could be checked, because early diagnosis is the key here. This is one of my favorite all-time glaucoma slides. We use it all the time in our different presentations. What it essentially shows is that spectrum of undetectable disease, which is most people out there who don't even know they have a diagnosis, all the way swinging to the right to functional impairment. It also shows the importance of reducing that risk of damage by treating those people early on who have undetectable disease so that they don't further down the road develop loss of vision, structural and functional. How do we evaluate people with glaucoma? We check intraocular pressure, we do slit lamp exam, we do gonioscopy, and every now and then a patient will tell me, I haven't had that done well. We do that about once a year, where we look at your drain or access to your drain to see if the angle is either open or closed. Because you could have an open angle glaucoma, and as you get older, as your cataract gets larger, your angle could actually slowly become compromised. So that becomes really important for us to do. And mostly also important is evaluation of the optic nerve head. In testing, the most dreaded visual field test, but we'll be champs about it because it's something we absolutely have to do. There are other things like nerve fiber layer analysis. You may have heard the word OCT, disc photography, pachymetry, corneal hysteresis. There's some things that are newer, and I'll explain why those things have helped us as we treat patients with glaucoma. This is what a normal visual field test looks like. On one side is a wider frame visual field, and on the other side is a more central visual field that tests your central 10 degrees. We try to decide what test is best for you, because if you've lost peripheral vision, there's no point putting you through a test that's going to tell us what we already know. Instead, we focus on a 10-2 or 10 degrees of field, visual field that is more informative to us in keeping the vision that you have left. With glaucoma, these are visual fields. This is actually Dr. Feldman's slide. He might recognize it. It shows how over time, sometimes despite the best things that we do, and this is kind of an older slide, but as you look from the top to the bottom, it's the same patient, one eye versus the other eye. And as you go further down, even if you just look at the grayscale, which is the black and white picture, you would see that the areas that appear whitish, which is the area you see out of, tend to shrink over time, while the darker area tends to expand if glaucoma is not stable or controlled. The visual field test is really important to telling us exactly how things are doing so we can reset and do something different about your treatment. What you see or may see is this, kind of a shrinking of your visual field. The way most people describe it to me is that my vision is dim, because you don't exactly realize that your vision is creeping in on you. There are some groups of people who have visual field loss that is more central, and that is kind of catastrophic, because everything we do here in glaucoma is to preserve your vision, and if you lose peripheral vision, okay, at least you still have central vision. But when you lose central vision, as we see in certain types of glaucoma, like normal tension glaucoma, that could impact your function. And so sometimes you may come in and say, I see okay, but we do a visual field that shows central loss. It becomes sort of critical that we make some drastic changes, because your feeling of seeing okay now may not remain that way, and we don't want you to lose vision that is going to be meaningful to you as years progress. The OCT is a tomograph. Essentially, it measures the thickness of the nerve fiber layer. And some of this technology evolved probably in more recent times compared to when we first started treating glaucoma. And having access to this also helps us, in addition to things like your visual field, know whether you're losing the layers of your nerve fiber layer so we can make the proper adjustments to taking care of you. The disc photograph is probably the oldest way we followed patients. We would look at that optic nerve, which is that circle, that disc in the center. We look at the lighter, pale area in the center, and we will try to judge from serial pictures to see whether the size of that cup is increasing over time. Being able to see a hemorrhage like that was a cue, or is still a cue, that something is not going well. We put that all together in something like this, the OCT, the pictures, your visual fields, and we then make an assessment of how you're doing over time. Every time you come, you get a pressure check, one or the other of these tests, to establish stability so we can, in the end, preserve your vision. The good news, or should I say the other news, there are some, with advancement in technology, there are some things that are coming to the forefront of how we take care of patients. The opportunities to do some of these things at home. I'm so sure you guys have gone to the eye care booth where there's opportunity to be able to check your own pressure at home. There's the virtual reality filled home version. This is one of my patients who took a unit at home, and she had several tests done just to check to see if she was maintaining her visual field because she perceived that she was losing vision. So she had this unit we took home, we program it, she does the test by herself, and the result gets sent to us. I just talked about home tonometry there and being able to check your pressure, whether for a period or if you own the unit, as you will. The opportunity to check your optic nerve isn't quite there yet, but there's advances in technology to allow us to do some of these things at home so that you hopefully, as time goes on, will take responsibility for some of your care. In glaucoma, as a provider, we define, detect, and treat disease early because we know majority of people in the community are undiagnosed. We examine the optic nerve to detect early glaucoma, and even yearly visual fields can sometimes significantly, visual field loss can significantly affect patients' lives. Glaucoma patients need IOP lowering to further prevent damage. The goal of glaucoma treatment, however, is to minimize the lifetime risk of visual loss while we balance the need to minimize harm from treatment. A target pressure is usually set by the American Academy of Ophthalmology. That's usually 25 to 30% of where you start. But the goal of that intraocular pressure, that number, I tell people, is like a sleep number bed. There's a number for everybody. There's a range that we need you at, because not everybody, I have patients come in, my brother's pressure is 12. Well, yours doesn't need to be 12 because you're a different person. It's that pressure at which you don't get worse. The target intraocular pressure could be in the high teens, mid-teens, low teens. We need to treat aggressively to target, and we need to mind fluctuations in intraocular pressure, so compliance and adherence with therapy becomes really important. We have some great clinical trials that have shown us the importance of IOP fluctuation and the need to keep your pressure somewhat stable to prevent you from getting worse. There's lots of therapy for glaucoma now. It used to be different. As I took a look at Caroline's list of procedures that she had done, there's some things that she got done earlier on in the game because at that time, that really was all we had. I won't say it's a good time to have glaucoma because it's not a good time ever to have glaucoma, but if you do have glaucoma, we have lots of options. We have lasers, different types of lasers. We've learned more about lasers and the benefits of a laser. We have different types of surgeries that we can do, both traditional and minimally invasive procedures. And you'll hear about some of those procedures. Medications, there's lots of things out there now to treat patients with glaucoma. In a nutshell, this is how it works. Vaguely, it's about plumbing. We're either doing one of several things. Number one, you're reducing the amount of fluid coming through the faucet, reducing fluid production in the eye. Number two, you're enhancing the existing collector channels. So that means you're declogging the strainer or getting somebody to rotor-rooter that drainage system, the plumbing in your house. And the last thing, if that doesn't work, you need new plumbing. That's when we create new drainage systems in trabeculectomies and tube shunts. So that's really how it works. For right now, most of the treatments we have available are broadly divided into those groups. Reduction of fluid production, trying to clean up the current drain you have, or getting a new one. Back to the surgeries and procedures. Literally, this needs updating, but these are all the different devices and different types of implants and surgeries that you could possibly have, and some of those companies are out there supporting us. And it's because of advances in research and development that we're able to look at all of this and now have options instead of 3 or 4 boxes that will help to take care of patients. Despite all of that, we're able to take you as an individual, customize your treatment algorithm, whether it's with drops, mixing it with the different surgeries, to find what is suitable for, first of all, your type of glaucoma, and you as an individual, because everybody has a different rate of progression. Some people are aggressive progressors, some people are slower progressors. And we need to individualize treatment to make sure that we're addressing you as a patient, which is why you have your own target intraocular pressure. Living with glaucoma sometimes can be tough. But I would say some things, and you would hear it reiterated throughout the day. Work with your doctors and keep your glaucoma stable, whether it's showing up for your appointments, using your medications as required. Seek out resources to keep you informed about glaucoma. Go to the Glaucoma Research Foundation website. They have a book called Understanding and Living with Glaucoma. The AGS Cares. Their records, always carry your records with you. Come to events like this to find out what is new, and always ask questions at the doctor's office. Respond to any vision changes. If you notice something, talk about it. There is a good seminar I did a couple of years ago on the GRF website that talks about how to prepare for a visit to your doctor's office. Keep a notebook. We can't remember everything. Then sometimes we have to modify lifestyle, and we will hear about that today. The things we can do differently outside of these things that we have talked about that will help you improve outcomes. In summary, the patient journey has evolved. It really has. The way we manage glaucoma when Dr. Feldman first graduated is different from when I graduated, and is definitely different from the way it is today. With research and development and new technology, we've been given insight into disease and we've been provided better diagnostics and treatment tools. With organizations like the GRF advocating and joining the push to cure glaucoma with research projects that are collaborative, like the catalyst to the cure, we're hopeful for a time when there will be possibility of a cure. Even though there isn't a cure yet, let's live our best lives. Thank you very much.